Thanks very much. So our last two talks deal with the exciting development of percutaneous AV fistulas. And first, Dr. Mallios will discuss with us the Ellipsys vascular access system. Dr. Mallios.
Thank you, Mr. President. So I'm going to basically tell you a very exciting story that has been going on for about a year and a half now. This exciting experience to develop this new technique. And before doing anything, I'm going to ask you a quiz here, if you can help me. There is something wrong with this photo. There is something wrong with this photo. All these photos are photos of my patients operated by me or fistulas created or corrected. But there is something wrong with this photo. Anyone interested to tell me? Guess? I don't have much time, so I have to reveal. So what's wrong with this photo is that the patient is very healthy. Okay? Look at his blue jeans and his good skin and his shoes, and he's a young patient. He's not the average dialyzed patient that has a horrible arteries, calcified arteries, diabetic patient, previous surgeries with ruined veins. So unfortunately, we cannot do these beautiful radiocephalic fistulas that are perfect, but unfortunately we have major maturation issues for the majority of patients. And instead of that, when we cannot do a radiocephalic fistula, what we do is brachial artery inflow. The majority of centers, this is what I was doing when I was a resident. However, in between, there is an intermediate solution, and this is proximal radial artery inflow. And we actually described, in a paper published in Journal of Vascular Surgery, 1,400 patients, where actually what you get is a better artery, better quality, wider artery, but larger veins. You're still on the radial artery, so you don't have all these problems that you have with brachial artery. And I invite you to remember all the major problems and major disastrous, life-threatening fistulas are brachial artery inflow. So if you wish, for me, brachial artery inflow will remain an enemy. And essentially, when you want to call yourself a vascular access expert, what you want to be able to offer to your patients is the best possible fistula with the least possible interventions. So in this context, we came across with this device, the Ellipsys device, which is basically doing exactly that. It's creating a proximal radial artery fistula the same way that we were doing the surgical proximal radial artery fistulas, with a catheter that is using tissue fusion, the Ellipsys vascular access system, that with hidden pressure is creating anastomosis between the perforating vein and the proximal radial artery. So we published our early results, the Journal of Vascular Surgery, and I'm going to give you the updated results now. Between May 2017 and November 2018, we have operated 161 patients with excellent technical success, with 8 months of mean follow-up and 72 primary patency rates and 96% secondary patency rates. We didn't have any serious adverse events, we didn't have any high flows, we didn't have any still syndromes. We did about 9 superficializations. The average maturation time was 4 weeks, and about 10% of the patients we were able to do early cannulation, which means less than 2 weeks. I want to draw your attention, there was 0% declots in this patient. For 161 patients that we operated, we didn't have to do one single declot, and we didn't have to do one single PDA of a draining vein lesion. This is how it looks post-4-day post-creation. And I want to draw your attention to the fact that we didn't ligate any side branches or coiled any branches. I want to draw your attention in the distal radiocephalic fistulas. These are surgical fistulas. You see how the first part of the vein is getting aneurysmal? Because it's high pressure, there is only one single vein. But what is great with these fistulas is the multiple outflow. The radial artery inflow, which is lower flow, and the multiple outflow is what makes this fistula so great. And essentially, this is what we do with Ellipsys. We're creating a multiple outflow fistula, which is soft with lower pressure, and this is why you don't get all these complications with the vein getting tired, having to assume all this flow, one single vein. The cannulation, when you have only one cephalic vein, it's the same thing. as a surgical fistula. However, in some patients, you have a cephalic vein that is kind of disappeared later, and you have the median basilic vein. So what we did in these patients, and allowed us to avoid the superficialization of the basilic vein, was to place a plastic cannula, one in the cephalic vein, one in the basilic vein. In some patients, we even thought that the fact that this vein is well developed and we already have such good flow, and we know that we placed the sheath a few days earlier and we took it off and nothing happened, allowed us to assume that it might be safe to do the cannulation earlier and avoid the catheter. And so we did. This was a patient with previous infected fistulas, a good developed cephalic vein. We did percutaneous fistula, and we stick the patient in day 1. This is a day in clinics for me. You see that there is no sign of aneurysm. You only see the signs from the puncture in the cephalic vein, or some patients cephalic and basilic. A few patients more. This wonderful 85-year-old patient, you see here that he has a cephalic vein, some branches coming to meet again as a cephalic vein here. I lost him. I didn't know what happened with him. 1 year later, he came back. A wonderful fistula, sticking the artery here on the vein here. And you know, I was kind of tired. People saying that you cannot do a distal fistula. Actually, it's not FDA approved in the United States, but in Europe we have authorization to use it for distal fistulas. And we even did 4 seminofistulas. This was a previous retired chief of ICU. A distal seminofistula, first week after creation, 500 flow. Great images. And sometimes, you know, some people say we're cherry-picking patients. This patient came as a desperate case. Previous catheters, occlused central veins, failed fistulas, removed fistulas everywhere. What perhaps you're not able to see here is that she has a very beautiful percutaneous fistula that has been used for 7 or 8 months. So in conclusion, I think we can all agree on all these things here. And I don't think it's a future, it's rather a revolution, and I invite you all to be part of it. If you're here, I know that you like fistulas, and I'm sure that you all like Paris. So 30th of September next year, we're doing the second IBIS meeting, and you're all invited. Thank you very much.